Good morning. We are talking today about prescribed minimum benefits. Now, this is one of the most important pieces of the Medical Schemes Act, and it's important that you understand what your rights are regarding prescribed minimum benefits. So what I'm going to try and explain to you today is that there's 271 diagnostic treatment pairs, and then the government added two others, which is COVID and listeriosis, if you can remember. Then there's 25 or 27 chronic conditions, depending whether you add age to it and whether you add split diabetes 1 and 2. And then there's emergency medical treatment. So I'm going to try and explain all these in this presentation. So I want to start off with a prescribed minimum benefit, and that is the rare disease regarding Hunter's disease that was in the media in August 2022. So Zachary is 3 years old. He suffers from Hunter syndrome, and the treatment for elaprase, which is the medication that he needs, is exceptionally expensive. And the medical condition of Zachary deteriorated so that his parents applied to the Council for Medical Schemes, or they lodged a complaint with the Council for Medical Schemes, but because it took so long and his health deteriorated so drastically, they approached the High Court for an interim relief on the matter. Now, to decide whether something is a PMB, this Hunter syndrome, is this a PMB, and how does PMBs actually work, and what did the court find in this specific process? And it's a good lesson in how to deal with PMBs, because a prescribed minimum benefit, the diagnosis, the treatment, and the visits to the doctor, and all the medication, all of that, and if there's an operation that is needed, all of that, we understand, must be paid at cost, not at a medical scheme rate. So that protects us enormously. But because that is such a rich benefit, medical schemes then also find that it is like an open checkbook. So they have certain restrictions that they can place on prescribed minimum benefits. So before they pay something as a prescribed minimum benefits, there's specific sets of rules that must be adhered to. So the first step is we must look at, is this condition listed in Annexure A of the regulations, and is it listed as one of the diagnostic treatment pairs? Is it one of the conditions that is covered? Is it cardiac arrest? Is it a heart attack? Is it a Hunter syndrome as an example? Is it listed there? If it is there, then we have met the requirements of step 1, and it can be funded as a PMB, providing we meet all the other criteria. So Hunter syndrome, do fit there. The next step is that, and there's a specific code for that. And the next step is that we must now go and look at the condition, the treatment, and we call it in our language, we call it a basket of care. Does this basket of care form part of the prescribed minimum benefit level of care? And the ICD-10 code, the International Classification of Diseases code, do determine whether there's a certain number of those codes, 14,500, more than that, that is PMB basket of care. Now, in this case, unfortunately, that didn't wasn't provided in a court case, but there is an ICD-10 code relating to Hunter syndrome, and therefore it forms part of it. And also the nappy code, the medicine, the Elaprase that Zachary needed is a medicine, so there's a nappy code. So does that form part of the basket of care? The third step is the level of care. So the regulations in terms of prescribed minimum benefits specifically classify certain treatment that they will allow medical management, in some cases surgical management, in some cases radiology or chemotherapy. So what is that category? Is it part of the level of care for that specific disease? Now, for this specific disease, the the regulations refer to medical management. Then, in some cases, medical schemes also require you to do pre-authorization, that you get your pre-authorization, yes or no, and then they also might impose a specific, they can say to you that you're allowed to get access to prescribed minimum benefits, but that you must make use of certain designated service providers. There are exceptions. If you stay too far from a designated service provider, if it's an emergency, if there's too long a delay and it will harm your health, there's certain exceptions that is then allowed. So prescribed minimum benefits is really a very complex issue, because when they speak about the surgical management, and they say that there's a difference between how it's treated in the public hospital and the private sector, then the level of care that is available in the public sector will prevail. So they don't want our overservicing in the private sector to drive up cost. So that makes a lot of sense. But now that's very difficult for the consumer to understand. And that is where your intermediary can assist you and can investigate it for you and can then advise you on that matter. So why did the Medihelp not pay the account, and what did the court find? So Medihelp argued specifically that Hunter syndrome, according to the medical management and the ICD-10 codes, is only a palliative type of care, meaning you can only stabilize people, you can only make them comfortable, but there is no real treatment for Hunter syndrome. And also that Elaprase is not available in the public hospital. So that specific section that I just now referred to in the regulations. So Zachary lawyers argued that Elaprase is available in 4 provinces and in the most populated provinces. And then Dr. Klein from Sanofi also confirmed that Elaprase is supplied in the public sector, and therefore the court decided that Hunter syndrome is a PMB condition, then that it forms part of the basket of care, that there is no difference between the public and private sector, and therefore ordered the medical scheme to pay the cost for Elaprase. So that's a good example of how that is applied. Now, we don't need to go to the court all the time to do this. Your intermediary can assist you, and we do that very often. Assist people to exercise their rights, either by way of the dispute committee or complaints to the Council for Medical Schemes. So, if you have a disease that's on a chronic list, hypertension, diabetes, hyperlipidemia, your cholesterol, how can you make sure that that is paid without any co-payment? So you must first make sure that the disease is on the list. I mean, that's very obvious. So if you have diabetes, or there's a list of 27 conditions. Now remember, if you have let's say hyperlipidemia, cholesterol, your fasting blood test, your visit to the doctor every 6 months, and then the medication. All of that must be paid at cost. However, the medical scheme can require you to register that condition, and they can also require to make use of a designated service provider. So the next step is that you register the condition, that you meet the criteria. So if a person wants to use cholesterol medication and they don't have high cholesterol, then the medical scheme should not fund that. So do they meet the criteria? Okay, then the third one is medical schemes can then say to you that there is a specific amount of tests that you can do a year, and you can visit a doctor a certain amount of time. So they can say, yes, you can do a fasting blood test maybe once a year, and you can visit a doctor twice a year. They're allowed to give you that protocol. And then they can say to you also that there's certain medication. So they only pay for this medication and that medication and that medication. Now, Regulation 15H, subsection C, and Regulation 15I, subsection C, speaks about if the protocol or the formula is ineffective, cause or would cause harm, appropriate substitution must be made to that beneficiary. Now, what does that mean? It means that if you need, maybe because of your specific circumstances, your clinical condition, you need to do 2 fasting tests every year, then the medical scheme must make that exception. They don't need to do it for everybody, but they must make it for you. And if the medication is ineffective, cause or would cause harm, the medical scheme must make exception for you. They must change the medication. Now, I recently had a case that I sent to the Registrar of Medical Schemes a complaint. The person was on a medical scheme where he paid R4,500 a month, the medication 6,000 rand a month. So obviously the medical scheme will try and restrict and not approve that expensive medication. One can understand that. But he needed that medication. He was for 32 years on chronic medication. And his cholesterol went up. 2 months before he lodged the complaint, his cholesterol went up from a count of 11. That's after 32 years on this chronic medication that the medical scheme had. His cholesterol went up from 11, a count of 11 to 13.5. Now that's dangerous. Anybody will know that. That is exceptionally dangerous. There was certain other medication available that he wanted to approve. The medical scheme didn't want to use it, and he decided he's going to pay for it himself, 6,000 rand. In that month, his cholesterol dropped to 3.5%, so he could clinically prove that that exception is required and needed, and therefore the case was adjudicated in our favor, and the member now receives that medication of 6,000 rand. But that doesn't mean if I have cholesterol and I'm on the same medical scheme, that must be provided to me. But in his specific case, with his history of high cholesterol and the inability of his body to absorb the medication that was on the formulary, clearly indicates that the exception must be made for him. Okay. So, and that specific issue about the formulary and the protocol was also why in the Polmed case, there's a Hunter syndrome case with Polmed, where in that case, the member also succeeded. They said, yes, you have a protocol and a formulary for treating Hunter syndrome, but it's ineffective, cause or would cause harm, and therefore appropriate substitution must be made. So there's 2 ways that you can actually address a prescribed minimum benefit, and the Polmed case clearly indicates that to us. But when we speak about prescribed minimum benefits and to speak about formularies and protocols. Medical schemes usually use the word evidence-based medicine. Now, I've tested this with many people, and I asked them, and I've done international research, and I asked them one question. If I use the word based medicine, what do you think it means? And without exception, the answer is something like, there's research, it's not thumbsuck, it's proper, it's safe, it's cost effective, those type of answers. And they are 100% right. That is the definition. But in the South African environment, we have included another sentence, and that is of immense importance. And it is that sentence that compel medical schemes to have that exception on a protocol and a formulary. And they talk about evidence-based medicine means the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of beneficiaries. And then the sentence is added, whereby individual clinical experience is integrated with the best available external clinical evidence from systematic research. So it's that individual clinical expertise that is important to take into account. And that is a very important aspect of prescribed minimum benefits and the rights of consumers often missed. Then to look at emergency medical conditions. In that regard, there is 3 requirements for an emergency medical condition to be regarded as an emergency medical condition under the prescribed minimum benefits. So first of all, was the health event sudden or unexpected? Not something that you could plan. Not going to the doctor at 10 o'clock. Now, immediate. I need the treatment now, immediately. There are some exceptions to that, but the primary aspect is immediate. Did a health event require, as I say, immediate medical or surgical treatment? So not something that you can now phone a doctor and then come and see me in 2 hours' time. It's immediate. And the last step is, if the immediate medical or surgical treatment was not received, would it result in serious impairment of a bodily functions or serious dysfunction of a body organ or part thereof, and would it place a person's life in jeopardy? So that's the requirements. If you meet all 3 of those requirements, that admission to hospital or that treatment would then be an emergency medical treatment. Now, what if you are admitted for a PMB, or you go to a casualty ward for a PMB, but later it is clear that it's not a PMB? So let's look at this. So you have chest pains, severe chest pains, and they go through a triage. I ask you a couple of questions, and the doctor says, this looks like a heart attack. Now that is a PMB. So you're now at the emergency room, you present yourself there, they look at you and they say, we need to do tests. Now they do an ECG and they do bloods and they care for you. They make sure, they're now very concerned. The doctors are concerned. They think it is a PMB. It is a heart attack. So if the final diagnosis it is a heart attack, well, then the diagnosis, the treatment, and everything must be funded as a PMB, which means a cost. But now they find out that it is not a heart attack. Your ECG is fine, your blood is fine, everything is fine. They actually say that it is not a PMB. It is anxiety. Now what now? Now you pay all that cost? No. all the costs up to the stage where they decided that it is not a PMB. All the costs up to then is paid as a PMB. Thereafter, it is paid at scheme rates. Now, there's various sources that you can go and look at. The Council for Medical Schemes provided 3 documents, newsletters to the industry. They call it a CMS script, and where they actually refer to that and confirm that as a matter. So we are really protected in terms of prescribed minimum benefits. Yes, we mustn't abuse it. Yes, we must register it. Yes, we must keep to the rules. But when we do that, we are protected. Where can you get more information on PMBs and your rights as a medical scheme member? You can go to the Facebook page, Medical Schemes Explained. You can go to the website, medicalschemesexplained.co.za, and you can also purchase the book, Medical Schemes Explained, and you can get it on the website, medicalschemesexplained.co.za/book/buy. I hope you enjoyed this video. I hope you learned something. If you want more, please check out these sites, and I hope to see you soon. Thank you.